Hi everyone, welcome back to the TinyDocs podcast series, Pediatric Interview Edition, your source for the clinical thinking station of pediatric training interview in the UK, brought to you by the British Sudanese Association of Pediatric and Child Health, or BSAP-CH in short. I'm your host Isra Ibrahim, and joining us today both of our presenters Guiria Ibrahim and Hanan Aliab to present real-life demonstration case of clinical thinking station. So, without further ado, let's dive into our episode.
طيب دكتور جويرية, you have a child who is 6 year old presented to you with history of fever, vomiting, diarrhea, and you found him tachycardic with a heart rate 160, hypotensive, and having capillary fills time of 4 seconds, and we coming you to the ER. How you will approach this child?
So it looks I'm dealing with a very sick child who is in shock. I will put my differential. Most likely, this is patient is having maybe he's having hypovolemic shock secondary to the dehydration, or I will also consider septic shock as this child is having fever. And also, I have to consider cardiogenic shock. Maybe this child is having myocarditis or other types of sign of shock. So I have to activate the emergency response system, and I have to inform my senior immediately and delegate the role to my teams and to print the protocol of shock. And I have to make this patient in resus room. Immediately, I will push this patient to the resus room, and I will connect him to the monitor, cardiac monitor, pulse oximeter, and apply for him oxygen by 100% oxygen by non-rebracing mask. Then I have to approach this child by an ABCD approach. I will start by the airway. I have to ensure patency of the airway. If not patent, I have to consider opening the airway by an airway opening maneuver. Then I have to move to the respiration. I have to assess his respiratory rate, effort, any sign of respiratory distress, and to make sure about his air entry. And I will continue to monitor his SpO2. Then I will move to the circulation. I have to assess circulation by assessing his central and peripheral pulses, and his capillary fill time, his color, and his blood pressure. Most likely this patient in shock as he is hypotensive, decompensated shock. Then I have to insert two large bore IV cannulae. If failed, I have to insert an interosseous line. I will start to expand the circulation by crystalloid fluid. I will start by 20 ml per kg, and then I have to titrate the fluid and to reversing the circulation and to obtain normal capillary fill time and normal level of consciousness. Then at the same time, I have to take blood for complete blood count, full blood count, inflammatory markers, blood gas, renal and liver function test. And also, as this patient is having fever, I have to take blood culture and coagulation profile and PCR for meningococcal and streptococcal also, and also grouping and cross matching. Then I will continue to monitor the response to the IV fluid. If after 2 ball, I have to consider to give this patient inotrope if there is no response after 2 or 3 bolus of crystalloid fluid, or if the patient develops sign of heart failure. Then, as this patient is having fever, I will consider to give this patient an IV antibiotic, third generation, either cefotaxime or ceftriaxone. Then I have to move to the D to assess the level of consciousness and the response to the fluid and to check his blood glucose. And also I have to consider to insert and urinary catheter to monitor his urine output and to maintain normal renal perfusion. Then I will move to the E to expose this child. I have to make sure about if there is any purpuric rash or other rash, and if this patient febrile, I have to give and antibiotic either by IV or oral according to the response of the child. Then I have to update the family by everything in the management, and I have to take a focus history. I will ask a detailed history about the event, about the vomiting, diarrhea, fever, for how long, and also if there is any rash, if there is any underlying congenital heart disease or congenital heart problem, if there is any family history of cardiomyopathy. And then I have to ask also about the medication history, if this patient is on a chronic medication, or if there is any medication in his environment. And I will ask about the event. Then I will do and head to toe exam to examine this child. Then, according to the situation and to the diagnosis, I will manage this child. I have to consider to admit this child to the PICU. And then I have to do a debriefing session to assess our performance.
Okay.
At the end of today's episode, me and Bisab CH would like to extend our thanks to our presenter, Guiria Ibrahim and Hanan Aliab, for sharing their thoughts with us. We hope that this episode has provided some sort of guidance for the clinical thinking stations. Remember, our journey does not end here. Be sure to check out the rest of our media outlet, our YouTube channel, our website, and the rest of our podcast. Remember also, your feedback is valuable. Please reach out and share your thoughts, questions, or suggestions. Together, we can improve and provide content that meets your need. Thank you for tuning in, and until next time, stay curious and keep learning.